I'd like to welcome up our first guest speaker. A lot of you will know him, Dr. James Lynam, our wonderful medical oncologist and advisor at the New South Wales Cancer Institute of New South Wales. James, I first roped into the first forum back in 2017 and a few since then, because he's just such a great speaker, and we really appreciate all the care that you provide your patients. We definitely shouldn't have favourite consultants, but he's one of our favourites on the down low, and he's just gives so much time to his patients, and he's been such a great advocate for the nurses and for the foundation, and really goes above and beyond. So we're really lucky to have you here today. Thanks, James.
Thank you, Sandy. That's a much more generous introduction than I deserve. It's hard following on from everyone who's already spoken. I'm not inspirational. You all are. I'm practical. I don't know what you've been through, but I've seen it from the other side. And what I thought I'd do today is talk about some of the practical things that me as a medical oncologist go through with my patients, and the common themes that we end up discussing in depth. I'm hoping, I've got 30 minutes, I'm hoping to get through things quickly and then open it up to questions so that people can ask what's important to them. Before I dive in though, I just want to reiterate what Sandy said about the Mark Hughes Foundation. I remember it before it was a foundation, and I remember the challenges that I and my colleagues faced in providing the care that we felt that people needed. And I think it's been completely transformed by the wonderful nurses that help us day in and day out. But yeah, I'll jump straight in. I've got three themes because we spend a lot of our times in the medical oncology unit discussing these themes. So I'm going to talk about steroids, I'm going to talk about driving, and I'm going to talk about MRIs. Again, I'm being practical, not inspirational. I do apologize in advance. Steroids. Everyone knows steroids. Everyone would probably have been on steroids and seen what they're like. Everyone will know this box of dexamethasone, which is the common steroid. And the way I describe the steroids is they're angels because they solve so many problems, and they're not so good in other ways because they cause so many other ones. And one of the common things that I end up talking a lot about is about the pros and cons of steroids. Steroids, or taking a step back, when people get symptoms from their brain tumor, there's two ways that people get symptoms. They get symptoms from the actual brain tumor itself, which is here, and they get symptoms from the swelling that occurs around the brain tumor, which is in pink. The brain can cope really well until it doesn't. That's why a lot of people will find that they're going really, really well and then all of a sudden get very, very unwell with their tumors. It's the swelling that generates a lot of those symptoms. And the swelling is what we use steroids for, to try and improve people's symptoms. And so when we give the steroids, we reduce that swelling and people feel better. Problem is, it causes a lot of problems. Steroids are great in short little bursts, but can have issues when people are on them for long periods of time. We talk about all the different side effects. It can cause really thin skin, which is really prone to bruising, so people feel like when they walk outside, they look like they've been beaten up. It increases the risk of infections, including weird chest infections. It causes body changes, and it causes weak legs. When we talk about body changes, this is not what steroids cause. All right? I wish it was. Unfortunately, we in medicine, the body changes that people get, we're insensitive as doctors, and the old ways that we would describe people who had been on steroids for a long period of time, and this isn't me, but we would call them lemon on a stick, which basically causes a lot of weight gain in the center of the body and really thin legs, a round face, and causes fat to come on the back of people's necks. The big issue I have with steroids, and the real big problem, is it actually causes really weak legs, specifically getting in and out of a chair, or getting upstairs. That's the big thing that we really, really, really hate from my perspective when people are on steroids. And the biggest reason I try and get people off of them as much as possible. So although people feel better on steroids, we try and get people off of the steroids as much as possible. But it is a mechanism for people being able to manage their own symptoms. And very commonly, if people have had issues, you'll call up the brain cancer nurses and they'll say, think about starting some steroids. And so my common recommendation to people is if you're feeling unwell, worried that you're getting symptoms from the cancer, have some dexamethasone. I usually start 1 in the morning, 1 at lunch. Try it for 3 to 5 days. If it hasn't made you feel better by that point, it won't, and stop it. If it does make you feel better, then we need to try and gradually reduce that dose down. If you stop it all of a sudden, if you've been on them for a while, you will fall into a heap and feel really, really washed out. But if we can drop it down to a nice level, we can get people off of them, that's great. Some people, we can't get off the steroids. We get to a level where if we go any lower than that, they get very, very unwell. And so what we want to try and do is get down to the lowest possible level. So steroids are key to helping manage the symptoms of the cancer, but they cause some issues. Driving. This is probably one of the things I end up talking most about. As everyone would know in this room, the problem with the diagnosis of brain cancer is it affects people's independence, and one of those main drivers is driving. The questions I ask people to ask themselves about driving is, when you've had your diagnosis, if you reflect, can I drive? Do I actually have the capability to move from the accelerator to the brake, to see everything around me? Should I drive? You know, is this something that I, reflecting on myself, have the capability to do? And then unfortunately, within an Australian legislative framework, excuse those terms, may I drive? May I drive is probably one of the bigger issues, in that according to the Road Transport Act, anyone who has a medical condition that could affect their ability to drive has to report that to the driving authority. This is an old slide. We base our recommendations about driving or not based on a document called Assessment of Fitness to Drive. It's updated every few years. This is from the 2018 version. We're up to the 2022 version at the moment, but it's a good little framework which kind of helps. Unfortunately, one of the common things that people have when they present with brain tumors is a seizure. Seizures immediately mean that you're no longer eligible for an unconditional license. You have to register with Ausroads and the New South Wales saying that you've had a seizure. And if you had one seizure, you're definitely not allowed to drive for 6 months. That can actually be 12 months depending on other features. If you've had more than one seizure, you're unfortunately not allowed to drive for 12 months from the time of your last seizure. This is a big issue, obviously. We talk about this regularly with my patients. The other thing is about brain surgery. Again, this is an old slide. It's not actually accurate anymore. It used to be that after brain surgery, you absolutely weren't allowed to drive for 3 months. That's been downgraded to basically up to the surgeon. But the usual cutoff, or the recommended cutoff, has now been increased 6 months. However, the surgeons have flexibility in determining how long you shouldn't drive for. The important thing about this is that as part of the assessment following driving, we look at something called a deficit. And basically we judge the deficits as the health providers to say, well, look, are you safe to drive? And the other thing to say about when we're thinking about safety to drive, we're worried about your safety. We're also obliged and required to be worried about everyone else's safety on the road. And the way I describe it is if your 5-year-old daughter or granddaughter were to jump in front of the car, would you have the capability to stop in time? One of the things that we look at with deficits is occasionally we recommend that people have what's called an occupational driving assessment, where we refer people to a very specialized specialist who will actually take people out on the road and assess their ability to drive. And that's there. Unfortunately, that comes at a cost to the person, but it's sometimes a necessary barrier before we can actually sign off people on getting their driver's license back. When we talk about deficits, what are your doctors looking at? They're looking at physical issues. So whether that's weakness on one side of your body, be it the brake, be it you're kind of driving your right foot with being able to move from the accelerator to the brake. It's looking at your visual field, so being able to see out the sides of your eyes, and looking at coordination. Are you able to kind of move things properly? We also think about the processing. So do you have the necessary kind of reflexes to get onto the brake pedal? Are you understanding everything that's coming in when you're driving at 100 kilometers an hour? Is there a high chance that you're going to get lost? These are sort of things that we think about. And then we think of other things. These are the tricky things, and these are some of the things that we really struggle with as the clinicians in insight. Does the person in front of us understand and comprehend the problems that are happening? Judgment and attention and concentration. Can people kind of focus well enough? These are all things that we consider, and if we have concerns, we will usually refer people for the occupational driving assessment. With regards to the occupational driving assessment, there are actually lots of local providers, but there is a website where you can actually, Occupational Therapy Australia, so OT-Oz, and it's basically got a map where you can actually look and actually find who the driving assessors are around you, and then you can click on something and call them up. Again, comes at a cost, and it's not cheap. Anywhere from $600 to $1,000 for the assessment. Now, I mentioned that unconditional or conditional driver's licenses. So the driver's license authority. One of the things about your doctors is that we actually very rarely will talk with the driver's authority. So we're bound by confidentiality issues. So when people are diagnosed with a condition that affects their ability to drive, it's up to them to inform the driver's authority. We don't do it as your providers. We will only contact the driver's authority if we had grave concerns about someone's ability to drive and they were still driving. And I've never had to do that. But the other thing is that if you were to have an accident and having not done this, if you were driving without having actually gone through or driving when you shouldn't have been, it has significant implications, both legal and ethical. You can be held responsible. Insurance will not provide coverage. So there's significant implications with it following an accident onto both yourself and your cover, but also the implications on the people that may also be injured in such a accident. Okay, I'm rushing through it. Apologies, and again, not exciting topics, but I thought they'd be interesting to kind of see how we deal with some of these things MRIs. Everyone in this room knows what an MRI is. MRIs. This is what we see at the end on our screens. All right, they are incredibly sophisticated tests. They're amazing. Amazing science goes into an MRI, and we can get so much information about them. And for brain tumors, they are the best test. They are good at differentiating between cancer and non-cancer. They can suggest when a tumor might be a high grade or low grade, and they're absolutely vital for planning surgery and radiotherapy. As a medical oncologist, they are the best test. They're not necessarily a good test. And this would be probably a theme that might have been discussed with several of you, how MRIs are very useful, but can be incredibly complicated. When we look at an MRI, we look at something called contrast. So that's when they inject you with the dye. And what we're looking at is areas where the dye gets taken up. So high-grade tumors, as part of their process, what they do is they change the blood vessels around the tumor, and they try and get a lot more blood into the tumor tissue. And so when we inject people with contrast, the high-grade tumors will light up because there's a lot more blood flow in that area. And it gives us a nice, great little picture of this is where that high-grade tumor sits. And contrast is really useful for highlighting that area. Now the problem is contrast is excellent at highlighting high-grade cancer, but every time we give people radiotherapy and chemotherapy, it causes changes as well. It causes, very often, increased blood flow into dying cancer. And so when we actually treat a cancer, things can actually look much worse on an MRI. And so we can do this MRI before people have radiotherapy and an MRI after people have radiotherapy. And I'll take it sideways. In other types of cancers, we do a scan before they have treatment and a scan after they have treatment, and we can see if that cancer's shrunk, and we go, yes, it's working, or it's grown, no, it's working. In this type of tumor, it works differently because after the radiotherapy, the scan could look dramatically worse. And very often, that's due to actual treatment as opposed to the cancer. And so we're in this situation where the scan looks worse, and we sit there and go, actually, no, we think that's a good thing. So we're going to keep going. And this is one of the challenges with MRIs, is that they're not very good at assessing treatment in the immediate term. It's something called pseudo-progression, which is a term, fancy term saying things look worse, but it's not because the cancer's getting worse, it's because the treatment's working. And this is kind of an example. You'll have to take my word for it. But, actually, I'm going to grab that. We've got pre-biopsy or post-biopsy right after surgery. There's a big hole here, and this big hole in the skull. And this is usually what this is some blood flow after surgery. So this isn't necessary. After radiotherapy, that whole area is taking up a lot more blood. And it looks worse because we kind of say, well, look, if it's bright, then that we're worried that that's cancer. 3 months later, it actually looks probably a little bit worse again. This area here looks a little bit more dramatic. At 6 months, it actually looks like it's starting to shrink. And at 12 months, it's definitely shrunk. So this is a situation where things look worse, but it's actually a good thing, and things are actually shrinking over time. And it's one of those challenges that we face, and it's a conversation that I tend up having very commonly, including last week with one of you guys in here. The other thing that we look at on the MRIs is not necessarily all the high-grade tumors, but also most people would have heard that the problem with high-grade tumors or GBMs is what we call a kind of octopus type issue, that we can see a big lump of tumor here, and the surgeons will go in and try and cut all that out, but we know that there's these tendrils of cancer that escape out of that big lump. And are there despite the surgery and despite the radiotherapy. These tendrils look like this on the scan. Problem is that swelling also looks like that. And so one of the other challenges that we face is that when we have this, what we call flare around the cancer, we're not entirely certain if it's cancer or swelling. If people have a lot of symptoms, we'll always give people steroids to try and reduce that swelling. But if the symptoms don't really settle, we have to say, well, look, it's probably the cancer. And it's again one of those challenges where an MRI gives us this information, but we don't necessarily know how to interpret it. And these are some of the challenges that we face when we're kind of discussing these sort of things. And yes, MRI is a great, great test. It's just not a very good one at times. That's all I was going to talk about. And again, I'm really sorry to kind of dump these sort of things, but these are the most common conversations I have with my patients. But I wanted to get through things quickly to see if there's actually any questions that people wanted to raise themselves, and very happy to talk about anything. Yeah.
If anyone's got any questions, I'll come around with the mic.
And also very happy if no one has any questions.
I've got any questions for James? While he's here, down the back.
Oh gosh.
Hi James, my name's Pat. I just wondered if you could talk a little bit about the thing that I had most about steroids, which is the impact that they have on people's mood and mental health, and just maybe a little bit about, just stopping it suddenly is also a thing that won't just make your body feel lousy, it'll make your brain feel lousy, and your mood will drop, and that can be a really difficult thing to manage.
Sorry, the audio here, sorry.
The steroids.
Yes.
Impacting mood.
Oh, the steroids affecting mood, yes. Yes, yes. Sorry, I didn't even mention all those sort of things. So steroids, again, amazing drugs. And a lot of people who start them find that they have this amazing pep and feel, yes, I'm ready. Let's go. I got more energy. We do know that it does increase people's anxiety and can sometimes increase people's aggression as well, being on higher doses of steroids. We term it sometimes roid rage, where people on higher doses of steroids, their mood and their personality shifts and they get a lot more short-tempered. That obviously is a problem, and it's a reflection of the higher the dose, the more likely that is to happen. And another one of those reasons why we try and drop the steroids down. I mentioned also that if people are on steroids for a long period of time, we absolutely just do not stop them flat. We don't go cold turkey. People feel horrible if they've been on steroids for a long period of time and then just stop them all of a sudden. We always have to drop it down, and even people who've been on them for a while, even if with a small drop in the dose, they can notice that they'll have a bit of a dip. Usually what happens, that dip happens for about a week, and then they kind of pick up a little bit, and then the next drop, they'll dip again and then go back up. Yeah. So I'm not sure if that answered your question.
Thank you. I think the terminology is correct for doing it's not. You've talked about MRIs to explain some limitations. The progression from, I believe it's STUP 1 to STUP 2. How much does that MRI influence, or if at all does it influence that progression or that treatment? Does it titrate it at all, or is it irrelevant at all? Where is that sit in the scale?
Excellent question. So the question, I'm not sure if people heard it, that you mentioned STUP 1 and STUP 2. So STUP 1 is basically combined chemoradiotherapy for 3 to 6 weeks, classically 6 weeks. And then STUP 2 is where we give people the chemotherapy monthly for at least 6 months. So that transition, as people would probably know, is that you have an MRI before you have your radiotherapy, which helps plan it. You have an MRI 4 weeks after your radiotherapy. And that's the MRI that people say is this going to affect, how well has the radiotherapy worked? And that's the MRI that usually looks very different. Does that MRI affect how we treat people? In my experience, it's only affected it once. Usually what we say is that MRI after the radiotherapy is the new baseline. And what I mean by that is we use that MRI to compare to the future scans. And that's the new baseline. So we don't use it to compare to before. I say once is affected because in someone that I know, the cancer clearly got worse through the treatment. And that MRI was very, very clear that it was the cancer that was driving the change as opposed to the treatment. But that's only ever happened to me once, despite a significant number of people I've treated. I hope that answers the question.
Would you use something instead of steroids to treat the symptoms? And is that, which I don't pronounce right, bevacizumab?
It is. Excellent question. And I should have actually raised this in the MRI issue. Bevacizumab is a drug that we use that can help get people off steroids. It's a drug that doesn't keep people alive any longer, but helps them live better. And what it does is it affects the blood flow around the tumor. Now, bevacizumab is incredibly effective. It has to be given into the vein, so it has to be by an infusion, so it's not as, you have to end up going into your oncology center regularly to get it. But it usually comes with minimal side effects and certainly doesn't have the same sort of issues as dexamethasone does. The challenge with bevacizumab is it's incredibly effective about working on blood flow and abnormal vessels. The moment we give bevacizumab, it's even more difficult to interpret the MRI. So actually, one of the challenges with bevacizumab is that people's MRIs look dramatically better. So I could give someone bevacizumab here, and this scan, you wouldn't see any of the lighting up. That's not because the cancer is better, it's because it's just the drugs affected the blood flow around the cancer, and it's kind of hidden the cancer on the MRI. So bevacizumab, very, very useful for symptoms. It makes what we call the response assessment to treatment much more challenging. Excellent question, and I'm sorry I didn't actually bring that up.
I'm a pretty firm believer in, I try not to take as much like prescription pills as I can. I try and go more natural towards that sort of way.
Yep.
Do you know how much about using CBD oil and THC oil during treatment?
Interesting. That's one of the topics I had 3 years ago, but I've dropped it down. CBD THC. Again, I'll go sideways and think of this from a medical perspective, so excuse my framing. Everything I give based on clinical trials which have taken people and split them into two groups, and one group got this, one group got that, and which group did better, however we define better, we go with that treatment. CBD THC, we've struggled to do clinical trials on its effectiveness. So I can sit here and tell people this is the benefit of chemotherapy. This is what we would expect. This is the potential side effects. With CBD, we don't have those studies. All the studies that have been done in brain tumors, for example, have all been done on different doses of the drug and no what we call placebo, where no one actually got the drug. So I struggle to sit there and say, well, this is the benefit of CBD or THC. What I will say is that some of my patients absolutely swear by an improvement in people's quality of life with the medication. They feel much, much better. Either they're sleeping better, either their appetite's better, or odd pains that they had have settled. That in and of itself win for me, and I'm very happy for people to keep using it. Flip side of the coin, I've had some patients who tried THC and had horrendous paranoia. And I've had a couple patients admitted into hospital who've been close to psychotic at the time. That's extremely rare. I can only think of one or two that's happened to, but it does happen. So it's not an innocuous, not drug that doesn't come with side effects. With regards to the anti-cancer effects of CBD, that's one of the real challenging things. So there was a lot of press a few years ago about the anti-cancer effects of CBD. I would say for any normal cancer, there's no anti-cancer effect of CBD or THC because there's no mechanistic way that it works. Brain tumors, though, when we talk about CBD and THC, it's a drug that attaches and stimulates certain receptors that are present on nerves. On a brain tumor, there will absolutely be an interaction between brain tumors and CBD THC. What that interaction will result in is what we don't know. And I think what my general advice to people is, if you want to try it, go for it. If you feel better, excellent, keep doing it. If you don't feel any better, don't keep taking it as an anti-cancer drug, because it's probably not going to do anything. That's my usual thing. The other thing is challenging to get. You have to go to a registered prescriber. Sorry, if you want to do it legally, you have to go to a registered prescriber who will then prescribe it, and then you can pay a lot more money for it than you would getting it illegally. But it's then kind of allowed. So, yeah. Does that answer the question?
Yeah, it does. Yeah, because I used it during my treatment.
Yeah.
And I did find that it helped a lot. I've never used it to combat actual cancer.
Yeah.
But just treatment-wise, I believe it's very
Yeah.
because it completely killed my little antibody eggs.
So the best clinical studies that we have, so actually the best international study on, so there's a couple things. CBD has been found to help with spasticity, so that kind of real tightness that can happen in people with brain tumors, but it was tested in people with multiple sclerosis. And when they did that trial and they compared it to a placebo, they found that people actually had a lot more movement with CBD than they did with the placebo. Australia ran a very, very impressive study where they actually looked at chemotherapy-induced nausea, and similarly, they found that CBD was more effective than the placebo. So it definitely has a role in those sort of things. With regards to kind of other things like cancer-related pain, it's been shown to actually not be more effective than placebo in the studies that have happened. But what I tell people, like I said, if it makes you feel better, go for it. Yeah. And yeah, so nausea, it can work for nausea, it can work for helping people sleep, it can work for general well-being. Someone I've taken it for anxiety, which I don't think is the recommended way to do it, but generally people have said this symptom was better on it, so yeah. What time have I done on that?
I was just curious, a couple of years ago, or maybe the last year, you were talking about immunotherapy and how it didn't necessarily work with brain cancer.
Yeah.
But you're trialing that now, and it's
So, excellent question. We have to talk about Richard Scolyer, obviously. You know, Australian of the Year, melanoma pioneer, and you know, GBM has a GBM. He put himself on immunotherapy, and it seemed to be successful for a period of time. When we talk about immunotherapy, it's a completely different way of attacking cancer. When we talk about chemotherapy, it's what I call napalm. You know, it attacks cancer and it affects everything else around it. Immunotherapy is the immunotherapy that we use at the moment ignores cancer. What it does is it boosts people's immune system, and the hope is that boost will cause the immune system to go and find cancer and attack it. It's incredibly effective for certain types of tumors like melanoma, lung cancer, bladder cancer, those sort of things. The current drugs that we have don't work in brain tumors. We've run multiple clinical studies. One of the ones that we ran in Australia, including here in Newcastle, suggested that immunotherapy might actually, people did a little bit worse on the immune therapy than they did on the standard treatment. Suggested that wasn't proven. Those drugs that we have at the moment aren't effective enough for brain tumors. Are there trials that we're looking at to try and get it effective? There are trials that are starting, because we have to think of it in a slightly different way. The way I describe it is the current immune drugs, they take off the brakes of the immune system. Like I said, they boost the immune system to go and attack cancer. That is non-selective. It basically just goes wherever it wants to go. What we need to do is figure out a way of flagging brain tumors to the immune system so that it knows what to go and hunt for. That's what we're struggling. That's a really, really, really complicated and tricky thing to do. But there are clinical trials that are happening. Most of the trials that are happening at the moment are what we call phase 1 studies. Phase 1 studies are important. They're basically when you take a drug and put it into a person for the first time, and the drug looks really great when you're doing things in a petri dish, but you have no idea how it's going to work in a human. More importantly, you have no idea what sort of side effects it's going to have in a human. So phase 1 studies are those studies where basically they're trying out the drug for the first time, and they absolutely want to know whether the drug works, but the main priority is seeing if we increase the dose, at what point do we end up causing a lot of symptoms or side effects from that drug so that we can find out what's the right dose to give people. Great, I'm sure I'm over time. What time is it? Sorry, I don't have my watch.
Wonderful, thank you very much, Dr. Lynam.
Thank you.